good afternoon, everybody. This is really a privilege for me to get to start off the year's grand rounds and to talk a bit about our programs here at Dell Children's and Dell Med in pediatric and congenital heart disease. Let me first say that I have no disclosures relevant to this presentation. So in being invited to give this talk, it was suggested that perhaps I give an update on our program here. And I thought that it would be interesting to the audience to talk about the ways that this has relevance to the greater world of cardiovascular health. So these are the objectives of the talk: to review our integrated practice unit in pediatric and congenital cardiac care, to examine the opportunities that we have for expanded outcomes analysis, and then correlate some of this work in pediatric cardiovascular disease with benefits to adult cardiovascular well-being. Congenital heart disease is common, and it's unfortunately highly lethal. About 1% of the population will be born with a serious congenital anomaly, and about a quarter of them will need an intervention in the first year of life. The last several decades have shown a significant improvement in outcomes for patients with congenital heart disease, but as will be demonstrated several times in this presentation, we still have very significant outcomes disparities, and this, of course, is troublesome to all of us. There are also performance disparities in various centers that take care of children with congenital heart disease, and these two slides highlight data for the arterial switch operation for transposition of the great arteries. And as you can see, there's a wide range of mortality differences depending, frankly, on the accident of birth, where one happens to be born and what center one gets to for a certain operation. That shouldn't be. So why now? Why here? Why at all? It's an unusual time in history in Austin. There's a big need. Essentially, we have a blank canvas, but we think we have an opportunity to do things better and address some of the lessons we've learned over the last nearly 30 years. And it's just wonderful to work with all these great and passionate people. Now, it would be entirely inappropriate for me to give a grand rounds and not talk about what's going on. Of course, we've been dominated medically by the reality of the pandemic. I was just reading before this grand round started that just today, Johns Hopkins confirmed over 200,000 deaths in the United States. And with the current trajectory, COVID is set to be the number 3 killer in the United States after number 2, cancer, and number 1, cardiovascular disease. And then, of course, our hearts are breaking. Our hearts are breaking about the realities of societal inequities. Not enough can be said about this challenging reality, and we will talk a little bit about the healthcare inequities. And there's a conflagration going on our West Coast with the environment under assault. Literally, our hearts are breaking for the things that our society is struggling with. So at many levels, it's a somber time, but we have a reason to be a nation in tears. But I'll really focus, hopefully more optimistically, on work that's been done in the care of the heart of a child. And I would encourage anyone who has some interest in this subject to read the biography of Helen Taussig, the matriarch of pediatric cardiology, the one who really got this whole thing started way back in the 40s. And we all owe Dr. Taussig and her successors an incredible debt of gratitude. I also, of course, am biased, and I believe, just as Nelson Mandela so nicely articulated, there can't be a more keen revelation of a society's soul than the way it treats its children. So these are our patients. This is how they start out with us after heart surgery, and they become recovering children after heart surgery and growing children after heart surgery, and they become children approaching junior high, And then after graduate school, working, all of these children have the same condition, transposition of the great arteries. It's a uniformly fatal problem without surgery. Great vessels are, for reasons that we don't understand, malpositioned such that without intracardiac mixing, the outcomes are dismal. Imagine the reality that during my childhood, the half-life for a child born with transposition with intact septum was a few weeks. Now fast forward to this era where we expect essentially uniform survival. In fact, in the last 2 decades, this millennium, we've not had a patient succumb to transposition of the great arteries, either in our experience at Texas Children's and more recently here at Dell Children's, and this is part of it. We've gotten good at the operation. This is an artist's rendition of the arterial switch operation, which restores anatomy and physiology. The malposed aorta is transected. The coronary arteries, or ostia, are mobilized. They're translocated to the posterior located pulmonary root and anastomose. The arteries are then relocated, reconstructed, and the patient is immediately restored to normal physiology and essentially normal anatomy. Some years before I came to Austin, I had the occasion to think about what is life like for a child with transposition of the great arteries. And so I got with one of my colleagues down on a big whiteboard in one of our rooms near my office and just wrote down everything I could think about. What happens to the patients? And I kind of ran out of steam at about 20 years. So that's part of what we're about here. And then I've thought more about what's an ideal program from the patient's perspective. Always open, never closed, full-time qualified pediatric focused staff, state-of-the-art everything, analysis, analysis, analysis. It's a complete program, meaning there are no big gaps. Patients are transported rapidly. Maybe that means a fetal program or even a fetal delivery unit. But what about from the perspective of the patient? What's ideal to them? Well, of course, they want a low mortality risk, low morbidity risk. They want the optimized opportunity for normal development, short time in the hospital, affordable and understandable, normal activity, and it feels right. Well, I got a glimpse into what this could be way back in 1990 when I had the good fortune to go to Royal Children's Hospital in Melbourne, Australia. And in what was at that time quite a humble and austere environment, I saw something that was just amazing. And that was results that were being achieved that no one else in the world was achieving. And so I decided I better write it down. So this is the start of that, the playbook as we've come to know it, that we've been evolving now for 30 years. Lots of notes and thinking and refining, and the basic premise. It's a simple premise, hard to execute. Outcomes are optimized by surrounding the patient with the greatest expertise possible at all times, not just sometimes, all times. So coming to Austin, we think we have, just in keeping with the underpinning of Dell Medical School and in a close and effective collaboration with our colleagues in Ascension, Texas, and specifically Dell Children's, the opportunity to rethink the way we care for children with congenital heart disease. And that is bullseye target on the child, on the family, and surround them entirely. And so we've been off to the races. This is our premise, to redesign the care of patients and families with congenital heart disease by developing a model system of delivery that is integrated, holistic, patient-centered, value-oriented, and technology-driven. I won't belabor the details of this slide, but we're developing the program as a team in an inclusive fashion. And this is a critical underpinning to our philosophy, and that is to include people in the design and development of the program. We started out as a swarm of itinerant entities. This was within about a week of me coming here. I got Post-it notes and put them on the wall, and they're color-coded depending on the employer. I look forward to the day when they're all the same color. But this is how we manage things. This is what we call our steering group. We met this morning, as we do every Tuesday morning. This is the operational functional unit of all decisions for our heart program. And you see there really the complete representation of all elements of our care team here at Dell Children's. We also wanted to listen to patients and families, so we had a retreat and heard them, gave them a lot of opportunity to tell us about their experience. And we started hiring people, and at last count, we're over 150 new full-time employee equivalents in our heart program here at Dell Children's. We did our first cardiopulmonary bypass case in July of 2018. This was a big day. The first day we did 2 surgeries at the same time, meaning we had 2 operating rooms outfitted to do surgery at the same time, a big step for the program. We have wonderful nurses at Dell Children's, and we work with them in a really hand-in-glove fashion, including doing a lot of simulation and education with our nursing colleagues. We have a wonderful new nurse manager in our cardiac care unit, Laura Morton. We developed essentially a graduation ceremony for our patients as they move through the unit. We were lucky to attract Dr. Liz McCullum here to lead our outcomes and transformation unit, which I'll talk about in a little bit. A seminal moment for the program was the recruitment of Dr. Aaron Gottlieb, the director of pediatric cardiac anesthesiology, really a preeminent, perhaps in my estimation, one of the best pediatric cardiac anesthesiologists anywhere in the world, and we're so fortunate to have Dr. Gottlieb here. And this is Dr. Gottlieb in the environment where she does what she does best, and that is lead the choreography. And Dr. Gottlieb and I wrote a paper about what we call the triangle of trust: anesthesiologist, surgeon, perfusionist. That's Mr. Blake Dennison, who runs our intraoperative perfusion service. And this is what you see every day at our hospital. It's a very effective partnership. We didn't have a cardiac ICU at Dell Children's. That was a critical deficiency, and I'm very grateful to Chris Bourne, Deb Brown, and Ascension leadership for getting that problem corrected. And it's a very appropriate, respectful environment, which now includes an intermediate care unit, which is run and managed by our great partners in pediatric hospital medicine. Dr. Mina Iyer and Jorge Ganem and their colleagues really do a tremendous job in the step-down unit arena. New advanced practice providers, a bunch of them led by Kim Crockless. We've got a new facility for them. They're the hardworking backbone of our day-to-day clinical operations. New machines, new heart-lung bypass machines, each about $250,000, specifically designed for the care of children, accurate, safe, reproducible perfusion. This was a big and interesting observation. So we use a lot of human cadaveric tissue in reconstructions in children. And historically, what had happened here was that a surgeon might find themselves in a situation of potentially needing this and having to order it from off-site, maybe from outside of Austin. Well, that's not consistent or commensurate with state-of-the-art care. And so through the great support of the hospital, we now have a homograph storage unit at the hospital with valves and tissue that we can use at moment's notice. That was a big step forward for our safety profile. We record everything. We record everything that we do in the operating room for use in education and in quality refinement. And this is really, really something that we're very attentive to. New and appropriately designated a respectful clinical consultation space was developed. And then a holistic and family-centered psychosocial team has been developed. And this is really, I think, very unusual, perhaps unique amongst cardiac programs, where we have dedicated clinical psychologists, clinical social workers, and child life specialists just for the patients and families with cardiovascular disease. We have envisioned and are implementing a novel approach, we think, to psychosocial issues. These folks are intimately involved in the preoperative and perioperative consultations with the families. We've developed a longitudinal follow-up mechanism, family advisory councils, introductory classes, and even social hours for the families. We were really, really lucky to convince Dr. Carlos Mary to come and join us here, and I can't say enough about Carlos in terms of his capabilities, vision, and energy. And one of Carlos's brilliant ideas was to rethink the way we do measurement and research, and Carlos coined the term Health Transformation and Design Program. And the premise is outcome measurement, research, and quality improvement in a rapid cycle fashion. And as I alluded to earlier, Dr. Liz McCullum runs that enterprise. So the idea is identify the meaningful outcomes, and we're forever refining this. What is important to the patients? What is important to the family? What is important to the hospital? And we have worked very closely, and I'll speak to this a little bit more later, in a roadmap initiative in collaboration with the Design and Value Institutes, which is a really special and unusual opportunity we have. Measuring, 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 and then using those measurements to improve outcomes. We participate in all variety of national and international registries. Of course, this is labor intensive, but critically important for us to know how we benchmark against our colleagues around the country. And it takes a lot of people, a lot of dedicated people, and you see there some of our team members here in the value and the design and transformation program. I won't belabor the details of our informatics efforts, but we are working closely with Ascension and UT Analytics to develop a clinical data warehouse that will hopefully populate our various registries and allow really facile analytics across the continuum of our program. Now, one project that is particularly exciting is this care mapping that I alluded to. It is for sure experimental. At present, it is novel. It's the idea of listening to families and redesigning the care journey of patients. So we started out with the idea of looking at patients born with single ventricle anatomy and physiology. For your reminder, these are patients who have one anatomic or functional ventricle. While it represents 10% of patients with congenital heart disease, it's responsible for most deaths as a category. Management involves 3 defined operations, usually in the first 3 or 4 years of life. Many programs have a standardized process. There have been improvements, but we still have a long way to go. So the poster child lesion is hypoplastic left heart syndrome, one single morphologic right ventricle, ejects to the body during fetal life and in early postnatal life through the pulmonary artery and a patent ductus, which has to be maintained with prostaglandin. It is 100% fatal without treatment. When I was in medical school, in the early 80s, there were no survivors with hypoplastic left heart syndrome. When I arrived at Texas Children's in 1995, there had never been a survivor with hypoplastic left heart syndrome in that hospital. Since that time, a lot of progress has been made. Stage 1 is putting things together, replumbing the anatomy, if you will. Stage 2, there are various ways we can do that. One, we can create a modified Blalock shunt with a shunt from the innominate artery to the pulmonary artery. And then another way is to place a right ventricle to pulmonary artery conduit. We'll save deliberation about which is better for another grand rounds. But suffice it to say, then stage 2, we take that apart, create a bidirectional Glenn shunt, superior vena cava and anastomose to the pulmonary arteries. And then stage 3, the inferior vena cava anastomose to pulmonary arteries. This is a Fontan palliation. Quite obviously, this is not a normal circulation. In the only prospective trial that's ever been done, and there's a lot of data in this trial, there were some sobering outcomes that have been elucidated. And the purpose of the trial was to compare treatment strategies, but one of the sobering findings is that for a child born with hypoplastic left heart syndrome, in the best collection of centers in the United States, the likelihood of being a first grader is around 60%. So clearly a big problem. This is the way that the providers have thought about it. We've thought about it in terms of the episodes of care. And I won't again belabor the episodes of care, but that's what we focus on. Well, there's a whole lot of life that goes on between those episodes. And more importantly, there's a whole lot of life that goes on after that that we don't know a thing about. So this is the idea of the journey mapping that Dr. Mary and his colleagues, again from the Value Institute, the Design Institute, many, many people, families, patients are exploring. And that is, what is life like at the time of surgery, between the surgeries, and beyond? And I look forward to the data and information they're going to share with us, and it's going to be, I think, incredibly exciting, but also really going to help us refine the way we take care of patients and families. Conferences are critical to clinical excellence. We work as a family, we share as a family, hopefully to the betterment of our patients. So this is our work week. We start each day with some form of conference. On Monday, it's a case management conference. Tuesday, a regional fetal conference. Wednesday, quality assurance. Thursday, so-called Fraser's Rounds, which is an educational conference. Friday, multidisciplinary review, which I'll go over shortly. So weekly case conference, reviewing every patient that we can, getting a consensus management strategy, talking about management of fetuses, educating each other about the specifics of the diseases and the perioperative management of the patients. We expanded the journal club to include the entire heart center. Expanded our quality assurance conferences and led by robust data analytics. And then every Friday, the team sits down and reviews every patient from the preceding week in a very detailed and frank fashion. These can be really difficult conversations, but we come in friends and we leave friends, but we leave no stone unturned when it comes to the well-being of our patients. We've had opportunity to quickly get in the complex game, and one of those is what I call applied bioengineering, that is putting machines in patients to support the circulation. This is the first patient at Dell Children's who was supported with a partial artificial heart or a ventricular assist device, is a so-called heartware device. This was a patient before surgery. After 2 hours of CPR, essentially moribund, being temporarily supported with ECMO, and then after surgery with a heartware device which takes blood out of the common atrium and returns it to the aorta. That patient and another with similar physiology, both of them have Fontan circulations, are now outpatients and being prepared for cardiac transplantation. Neither of those patients would have survived before having this device available to us here at Dell Children's. So that experience and the real clinical need of patients for cardiac replacement therapies drove all of us to push hard for the development of a transplant program. And this was a proud day when several of us signed the application for cardiac transplantation, and we were very pleased that in July our program was granted temporary approval for listing patients for cardiac transplantation, which we have done, and we look forward to our first transplant when a suitable donor organ becomes available. It's a great team of people, great dedicated folks, and I want to introduce you to some of the leaders, starting at the top of the screen. On the left, Dr. Byron Holt, part of a tremendous group of cardiologists who really, frankly, all predated us to a large degree here in Austin. Dr. Holt and his colleagues have been doing heavy lifting in Austin for a lot of years, and we're really pleased to be partnering with them in the development of the program. There's Dr. Dan Stromberg next to me, leader of critical care, Dr. Gottlieb, Dr. Carlos Mary. In the lower panels, Dr. Chesney Castleberry, who came here, was recruited to lead our heart failure and transplant program. My able colleague, Amy Links, who is our practice administrator. And then I can't say enough about Chris Bourne and Deb Brown, our CEO and COO, who are on the ground, boots on the ground every day here at the hospital, making it all work. Starting back in June into July of 2018, our predecessors were leaving, and then we took over essentially in September of 2018 and have gotten busier and busier. These are average daily census of cardiovascular patients at the hospital since then. We've been reporting our outcomes to our Society of Thoracic Surgeons, which is our national professional society, for a number of years. And they have been rating our program. It's a three-tiered rating system looking at a rolling 4-year outcomes analysis. Unfortunately, historically, the program had the lowest rating, which was 1 star. I'm pleased to say after 1 year of reporting, we brought the program up to a 2-star. We will not be satisfied until we're a 3-star program, and we're really focused on that. We're also focused on transparency. We produce and publish a program analytics data sheet every month and are completely transparent about our outcomes. And you see there are overall aggregate outcomes as compared to our national benchmarks as of earlier this month. I wanted to share with you a bit about our intensive care unit.
We have the highest level of expertise at the bedside taking care of these patients at all times. That goes for physicians, nurses, respiratory therapists, nurse practitioners. So we have a very skilled and dedicated team, and my role is to assemble that team and let them do what they do so well. My name is Dr. Daniel Stromberg. I'm Director of Cardiac Critical Care here at Dell Children's Medical Center. My role is to direct all the functions of the cardiac care unit here at the hospital. So one of the things that I love about our unit is that if you come on surgical rounds in the morning, you'll see cardiologists, cardiac nurse practitioners, ICU people, surgeons, respiratory therapists, social workers, the whole team. I'm sure I'm leaving people out, but the whole team is there because they're so interested in these children. So what the families will see is in the morning there is a large group of people thinking about, commenting on, worrying about the care that's provided for their child. And we include the parents in that experience too, because we want the parents to be part of that care team. And we also believe in transparency, so the parents are going to really see and hear about what we're doing for their child, and we value their input. They'll have, as I said, more personalized care. They'll know who these people are, and they'll have access to them. So I think those are parts of the unique experience in the CCU at Dell Children's.
The science and evolution of pediatric cardiology has evolved, and there are things that are being treated surgically now that weren't treated decades ago. My name is Laura Morton, and I'm the manager of our cardiac care unit here at Dell Children's Medical Center. A lot of emphasis has not historically been placed on the family dynamic of what their life now looks like to live with a heart baby. So something cool that our program is doing is getting a really good psychosocial lens into not just what we're doing inside the hospital, but what these families experience when they're having to manage pediatric cardiac care at their houses.
We're doing research that is at the forefront of the field. So we are looking at, for example, unique ways of resuscitating patients. We're looking at medications that have not been used before that may make a difference in how patients are cared for. So all of these things come together in this academic environment that really allow us to provide the best care going forward and learn from the past.
Well, I wanted to use that really beautiful video that my colleague Matthew Hooker created about our program to transition into what I'll end with, and that is some thoughts on how this might translate into an overall cardiovascular excellence imperative. The need is solid and real. This was a sobering article that was published in the Wall Street Journal earlier this year, kind of pre-COVID, but prescient, that heart disease is striking back even in healthy places. And it's disparate in its prevalence and virulence. Unfortunately, the South seems to have some significant disadvantage in cardiovascular disease and other parts of the state, which are deeply troubling. After decades of improvement in the mortality rate for cardiovascular disease, the last couple of years look like perhaps we may be heading towards an uptick. Not sure what to make of that. Coronary heart disease, stroke still predominate, but other forms of heart disease are becoming more and more prevalent and problematic. And one of them is in our own specialty, and that is adults with congenital heart disease, which is an important area of focus. We work with Dr. Greg Johnson, who is the only pediatric and adult specialized cardiologist in this part of the world. And Dr. Johnson has an enormous practice here in Austin taking care of these patients who had childhood disease who now have become adults. So there's opportunity for a lot of improvement. The American Heart Association has come up with this notion of healthy life expectancy. So we know what life expectancy means, how long we're going to live, but what is healthy life expectancy? That's how long we live before we start having problems. And the information is not all that happy. And as you can see, there are significant differences depending on where you live in the country. This is certainly becoming personally pertinent to me as I get into this same age range. But look at the things that affect healthy years: race, ethnicity, income, whether you live in the country or in the city, and your education level. Really important societal problems. How about this? My dear friend and colleague, Dr. Kayla Lopez, published recently in Circulation a sobering article looking at overall U.S. mortality related to congenital heart disease. And while it has decreased, there are significant disparities in mortality for males compared to females and for non-Hispanic blacks compared to non-Hispanic whites. Certainly we have a problem that needs attention. And then in this COVID era, there are scary things that are going on, scary things that we don't understand. Our colleagues at Ohio State really got out ahead of us on looking at athletes. These are competitive athletes and who had suffered from COVID, and unfortunately looking at MRI evidence of myocarditis, or inflammation of the heart muscle. Of 26 athletes screened, 4 had significant evidence of myocarditis. Now, what will happen to them? Who knows at this point? But we know that myocarditis can be associated with myocardial scarring and in some patients cardiomyopathy. Really important areas where we need to focus attention. We believe, as do now many people around the country and around the world, including Dr. Valentin Fuster at Mount Sinai in New York, and Dr. Fuster is an adult cardiologist, but he was a senior author on this important article in the Journal of American College of Cardiology, emphasizing that children present a window of opportunity for promoting health. These disease states that we treat in adult life, in many respects, get started in childhood, and so we have an opportunity. I'll share an anecdote. As a cardiac transplant surgeon, I've had the opportunity, of course it's a somber situation, where I go and retrieve a donor heart from a child who is a brain-dead organ donor. And I can tell you that some of the children's hearts that we retrieve, you can see significant atherosclerotic plaques in the aorta in children as young as 12 or 18 months. And that should be, I think, a really important signal for all of us. Now, finally, I'm going to end up talking about an academic medical center. So every time I get the opportunity, I talk about dispelling the myth that has been promulgated that having a teaching hospital somehow works to the detriment of the patient. I will say unequivocally that is patently wrong. There is no coincidence that clinical excellence is associated with academic medicine. It creates an environment of a virtuous cycle. The students, residents, and fellows push us to be better. Trainees come from all over the world and they're attracted to clinical excellence. And clinical experience drives the pertinent questions that need to be solved. So hopefully this raises the hair on many of the people who are watching this grand rounds. These are the top 10 hospitals as ranked by the U.S. News & World Report for treatment of cardiovascular disease in the United States 2019 into 2020. Several points to note. Number one, the Cleveland Clinic and the Mayo Clinic have remained number 1 and 2 for a lot of years. Number two, every hospital on this list is associated with an academic medical center. Number three, there are none of them in Texas. That's a problem. Period, end of report. That's a problem. Well, part of the solution is these folks. Without doubt, part of the solution is these people, like Taylor Taliaferro, my friend who I knew before medical school, who was our first rotating Dell Med student on our new program. We couldn't have had a better first student, and that's Taylor in the operating room with us. Or how about this? This is just a couple of weeks ago on rounds in our cardiac ICU, full of patients, critically ill newborns, patients with mechanical circulatory support ongoing. That's Mais, our second-year student, and standing right across from her is Charlotte, our rotating sub-intern. Every single patient in our cardiac ICU that morning was presented by either Charlotte or Mais. And I will also say that a rotating observer said, these young students are functioning at the level of fellows. Extremely proud of them. So I'm very biased when it comes to the University of Texas. I've been walking this campus for as long as I can remember. In fact, I was born here when my dad was a graduate student in engineering just off screen here. So I am a biased person, but when I hear what starts here changes the world, I believe it. And I'm one of those people that sits on the main mall and I contemplate these words that are inscribed on our tower. You shall know the truth and the truth shall make you free. So we're always looking harder and harder to find the truth. I believe the truth starts with clinical focus, the focus on clinical excellence in medicine, and everything derives from it. All the things that we know that are so important, medical education, research, philanthropy, collaborations, government relations, economic viability, none of it matters if we don't have the right clinical care. So that's going to be our focus here at Dell Children's, and we believe that we are off to a great start. It's a beautiful hospital led by great people, part of a very, very great system. A lot of exciting things going on. New medical office building, getting constructed as we speak. Brand new hospital out in north of town, getting started as we speak. Taking the problems to the Dell Pediatric Research Institute to try to make tomorrow better. But most importantly, it's the people. It's all about the people that surround these children every day, every night, every weekend, every holiday. They're the difference makers, and we should all be very proud of the associations that we have here in this program. The opportunities are tremendous. Thank you very much for having me give this grand rounds, and I'd be happy to answer any questions.
Well, thank you, Chuck. That was certainly a tour de force and a great way to kick off our academic year, Dell Med Grand Rounds. You truly do embody the mission when it comes to person-centered multidisciplinary care that rewards value. And it's an inspiration for all of us who have been trying to achieve similar results that you have. Before I get into the questions, and please post your questions in the chat, there's a couple comments that came through that I think are distinctly unusual for this type of format. I've not seen before, having moderated many of these. First is from Sarah Baker. Dr. Fraser performed my open heart surgery when I was 15 at Texas Children's Hospital. I'm a pre-med now and taking my MCAT on Sunday. So congratulations, Sarah, and thank you for joining us. The other is from Sam Dawson. Thank you to Dr. Fraser and his team for saving our grandson's life, aortic arch advancement and whole. Truly amazing work and care his vision has and is coming to fruition. Those are pretty unique to have those kinds of stories, but I can see why that makes it all meaningful and worthwhile for you.
That's why we're here, Kevin, of course. Thank you for sharing those. And we'll look forward to hearing about the medical school application.
Yes. Let me take the moderator's prerogative and ask the first question, and then there's some other questions that I promise I'll get to your question. So one of the things that's always impressed me about your field, Chuck, and your team in particular is how data-driven you are. And so I know that the Society for Thoracic Surgery has always been a leader in the development of clinical registries. It's really the foremost progressive entity in the world when it comes to clinical registry development and using that data. I was wondering, you showed us a picture in your boardroom, sort of sitting around the table, but I was wondering if you could give us just a quick example of how you use that data to improve care, and then really just maybe a brief comment on how you create that culture of continuous improvement, because I know the tendency is to say, well, the data's wrong, our kids are sicker, it's not risk adjusted properly, and many of us don't ever get to that phase of, well, let's use this data to improve on what we're doing. So if you could comment on that briefly.
Yeah, you're so right about practicing by anecdote. Now, sometimes anecdotes have value, but our memories are short, and we're influenced probably unfairly by either our recent good outcome or our recent bad outcome. So I've had so many examples of that in my career where there's been a strong opinion on one side or the other about an issue, and we went and got the data and dispelled the misperception. So we're doing everything we can to capture everything we can. And as you very well know, that's a tour de force. The systems aren't built to do that. It's one of the big, I think, misrepresentations of the electronic medical record era, and that is that things are readily extractable, and it doesn't matter which EMR you're using. It's a challenge. We need data architects, we need data analysts, et cetera, to be able to do that. Having said, there's a mountain of data that we can take advantage of. So we're just working hard to get at as much as we can and analyze it as quickly as we can. So in real time, every Wednesday when we have our quality conference, we start out with essentially our data analytics team. Our research nurses, our outcome specialists present on that subject, whether it be the cath lab or the ICU or surgery, our dashboard of clinical information and clinical data. And then when we have a real-time question about a patient, of course, sometimes we have to go to the literature to find out what data is available, just as you would in any other specialty. But if we can take advantage of the Society of Thoracic Surgeons database, we can sometimes do that as well. And all those other registries that we showed on that one slide, they're going to provide opportunities as well, because feeding those registries, we have to build a platform of the data analytics as well.
Well, thank you. Okay, I want to jump into the questions. There's quite a few here. The first is from George Arnold, who's from New Zealand. I think he gets the record for the furthest attendee for Dell Med Grand Rounds. What role do payers play in advancing or impeding progress in your program?
Well, I'm not going to have a very satisfying answer, because right now we don't have much interface with the payers. I hope that over time, as the program evolves and our relationships evolve, that we're going to have more engagement on that. There are, as I'm sure everybody knows, there are centers of excellence designations, which we will seek, which does give us some influence over these relationships. But right now, the payer relationships are handled at a level sort of beyond the scope of our program. We want to change that. We want to integrate the outcomes work that we're doing with the operational financial work that's going on, so that we can really work for that value proposition that we all feel is so important. But it's going to take time, but we're not there yet.
All right, thank you. Just another comment from Deepa Shah. Thank you for the awesome presentation. My son had the best time shadowing you as an undergraduate. Now he's interviewing for medical school. So congratulations to the Shah family. The question came in from Mo Levy, and that is there any effort to collaborate with other programs in the state or region?
Yes. Well, first of all, we automatically collaborate with them in the sense that we all share our data in our national registries. But we have talked about developing a UT congenital cardiac disease consortium. We're going to compete with the other UT system programs at certain levels, but we also have opportunities to collaborate with them in many respects, Mo. So it's on the very lengthy to-do list, which we look at every day, but we see opportunity to develop a collaborative consortium. If you think about between Galveston, UT Houston, Dell Med, UT San Antonio, and UT Southwestern, that's a lot of patients that get taken care of each year, and it gives us a lot of research opportunities and quality opportunities, frankly.
That'd be a great precedent for a lot of our specialties. Clay Johnson has a question. I'll ask him to turn on his microphone and video.
Yeah, sure. So Chuck, great presentation, and just, wonderful and inspiring work for all of us. So thank you for all of that. My question to you is really about where we go from here. So, your outcomes are superb, but these are unbelievably complex conditions, and obviously not all children have wonderful outcomes. So as you look at it and you think about it, where are the greatest opportunities? Are they in the OR? Are they in the hospital, in the care around what happens in the OR? Are they in the transition to primary care? Or are they in the hands of families and after all of this and before as well? And I know you thought about this, but I'm just wondering how where you're going to place your attention. Yeah.
Well, frankly, here, on a day-to-day basis, Clay, we're 99+% focused on clinical operations and getting the right team, the right equipment, the right environment, the right numbers of staff. So I guess I would call this the foundational phase of the program. Now, as we're doing that, we're collecting a lot of information, we're learning a lot, but I look forward to the day where the foundation is completely solid and we can move into the aspirational phase of the program. So part of that is to start to respond to the things that we're learning from patients and families in terms of the way we execute care here in the hospital and outside the hospital. And then we believe very strongly that this is transportable to other programs. We've already started to get some interest from colleagues around the country about the work we're doing. We think that this can be, the next evolution of congenital cardiac care. A lot of the inefficiencies and frankly cost that are related to our specialty are due to what goes on outside the hospital. Patients getting to the right place at the right time, right providers, et cetera. So that's where I think the most incremental gain is to be found, is getting the patients to the right place. And I'm not alone in that opinion. Our Congenital Heart Surgeons Society is embarking on a very prickly topic, and that is the development of authorized centers of excellence in congenital cardiac disease around the country. So that will be forthcoming. It'll be very interesting to see how that gets executed, but it's appropriate. It's appropriate. We have too many places doing this work in Texas, frankly. So I think that's where the biggest upside gain is to be found.
All right. Well, thank you, Chuck. I see we're getting to the top of the hour here. Again, I want to thank everyone for taking time out of the middle of the day to listen to Chuck. We had over 200 participants, which is pretty impressive, the biggest I've ever seen for this event. And again, Chuck, I just want to thank you for being an inspiration to the rest of us. I think it's quite amazing what you and your team have been able to accomplish in the short period of time that you've been here. I know there are even better things on the horizon, and thanks for setting the example for the rest of us. So thanks please, on behalf of our Dell Med Grand Rounds team, please thank your entire team for sharing that story with us.
Well, thanks very much. And thank you all for the opportunity. We really appreciate it.
All right, and we will look forward to seeing everyone back in December for Louis Sandy's presentation. Please stay safe, and we'll look forward to seeing you again soon. Take care.
Thanks, Kevin.